All right, we're going to go through female genital urinary system in two parts, and this is going to be the first part. As far as structure and function, we've got our external structures: vulva, mons pubis, labia majora and minora, frenulum, clitoris, vestibule, urethral meatus, Skene's glands, the vaginal orifice, the hymen, and Bartholin's glands. With the vulva, which is the outer area that you can see here of the vagina, it includes all of these other components as listed on here. I won't read them again, but you can see them each individually here in the area that's known as the vulva. The mons pubis, this is a round, firm pad of adipose tissue covering the symphysis pubis, and it becomes covered with hair after puberty. The labia majora, it's two rounded folds of adipose tissue that's extended from the mons pubis to the perineum. The folds become covered with hair on outer surfaces after puberty. The inner smooth, moist contains sebaceous follicles. The labia minora, this is inside those labia majora. They're jointed anteriorly at the clitoris, so it forms what's called a hood. They're joined posteriorly by a transverse fold, and this is the frenulum. The clitoris is a small pea-shaped erectile body, highly sensitive to tactile stimulation. And the vestibule, this is the cleft encircled by the labial structures, and they have numerous openings. The urethral meatus, this appears as a dimple just posterior to the clitoris. The Skene's glands, they're multiple tiny glands that surround the urethral meatus. The ducts are not visible, but they're open posterior to the urethra. The vaginal orifice is the opening that's located posterior to the urethral meatus. And the hymen is a thin, circular, crescent-shaped fold that covers the part or all of the vaginal orifice. Bartholin glands, these are on each side and posterior to the vaginal orifice. It secretes a clear, lubricating mucus during sexual intercourse. The ducts are visible, but open in grooves between the labia minora and the hymen. The internal structures we're going to go through here of the vagina, the cervix, on and on. I don't need to read this whole list to you, but you can see there's a number of internal structures as well that we'll go through. Here's a diagram of it. We have the flattened tubular canal, which is the vagina extending from the orifice we just talked about and backward into the pelvis. It's approximately 9 centimeters long. It sits between the rectum posteriorly and bladder and urethra anteriorly. The wall is created by thick transverse folds or rugae, enabling the vagina to dilate widely during childbirth. The uterine cervix, this is at the end of the canal. It projects into the vagina. In the female that is nulliparous, as in they have not had any children, the cervix appears as a smooth donut-shaped area with a small circular hole, which is called the os. After childbirth, the os is slightly enlarged and irregular. The anterior fornix in front and the posterior fornix in back form a continuous recess around the cervix. And behind the posterior fornix is another deep recess called the rectouterine pouch or cul-de-sac of Douglas. The uterus is pear-shaped. It's a thick-walled muscular organ. It's flattened anterior-posteriorly, and it's not fixed, so it's freely movable, and it usually tilts forward and superior to the bladder. The fallopian tubes, there's two. They're pliable, trumpet-shaped tubes, 10 centimeters in length, and they extend from the uterine fundus laterally to the brim of the pelvis. And then we have our ovaries. They're located on each side of the uterus at the level of the anterior superior iliac spine. The breast anatomy we've got here, we have our external structures, which are the nipple, the areola, and the Montgomery glands. and our internal structures, which are the adipose tissue, the glandular tissue, Cooper ligaments, tail of Spence, lymphatics, and lactiferous ducts. Moving on to our special populations. At birth, our external genitalia are engorged due to maternal hormones during the birth process. This dissipates after a few weeks. The ovaries are in the abdominal cavity during childhood, and the uterus is small with straight access and no anteflexion. As our patients grow older, the estrogen increases at the time of puberty and stimulates development of secondary sex characteristics. The first signs of puberty are breast development and pubic hair growth, beginning around the age 8.5, unbelievably, but up to 13 is when it usually starts. Signs usually are concurrent, but not abnormal if not occurring at the exact same time. Puberty takes about 3 years to complete. Menarche occurs during the later half of this sequence, just after the peak of growth velocity. Irregularity of cycle is common when it first starts out because of the girl's occasional failure to ovulate. With menarche, the uterine body flexes on the cervix. The ovaries are now within the pelvic cavity. This is something that you'll need to know. It's the Tanner's table that's used and has 5 stages of the pubic hair development, sex maturity rating, and it's helpful in teaching girls the expected sequence of sexual development. The data may not necessarily generalize to all racial groups. Mature Asian women normally have fine, sparse pubic hair. And our Black and Hispanic girls, they had pubic hair and had achieved menarche younger than our Caucasian patients. Right here, it's important for you to note in these stages that asymmetry of the breasts are normal during the developmental stages. In pregnancy, shortly after the first missed menstrual period, the genitalia show signs of the growing fetus. The cervix softens, which is a Goodell sign, at 4 to 6 weeks of gestation, and the vaginal mucosa and cervix look a little bit cyanotic, which is called Chadwick's sign. You can see it in the picture there, at about 8 to 12 weeks of gestation. These changes occur because of an increased vascularity and edema of the cervix and hypertrophy and hyperplasia of the cervical glands. The isthmus of the uterus softens. This is called Hedegar's sign at about 6 to 8 weeks of gestation. The greatest change is in the uterus. It increases in capacity by 500 to 1,000 times its non-pregnant state. It occurs first because of hormone stimulation, but then it moves on because of increasing size of the fetus. The non-pregnant uterus has a flattened pear shape. Early growth encroaches on space occupied by the bladder, producing a symptom of urinary frequency in our pregnant patients. By 10 to 12 weeks, the uterus becomes globular in shape and is too large to stay in the pelvis. At 20 to 24 weeks, the uterus has an oval shape now, and it rises almost to the liver, displacing our intestines superiorly and laterally. Clot of thick, tenacious mucus forms in spaces of the cervical canal. This is called the mucus plug, and this protects the fetus from infection. The mucus plug dislodges when labor begins at the end of the term, producing a sign of labor called bloody show. The cervical and vaginal secretions increase. Increased acidity occurs by action of Lactobacillus acidophilus, and this changes glycogen into lactic acid. The acidic pH keeps pathogenic bacteria from multiplying in the vagina, but it increases in glycogen. This causes increased risk of a fungal or yeast infection called candidiasis during pregnancy. With our elderly population, on the other hand, we have cessation of menses that occurs generally around 48 to 51 years, but it can be variable from 35 all the way to 60. Menopause includes preceding 1 to 2 years of decline in ovarian function, so our menses are irregular, they're lighter, they're farther apart. Ovulation can still occur sporadically after menopause. With our ovaries, they stop producing progesterone and estrogen. Cells in the reproductive tract are estrogen dependent, so this cessation causes a dramatic physical change. Atrophy, 1 to 2 centimeters, are usually non-palpable after menopause with our ovaries. With the breasts, atrophy of glandular tissue, this is related to menopause, can begin as early as 35 years. That's important for you to know. And they decrease in size. The sacral ligaments start to relax and pelvic musculature weakens. So the uterus drops and may protrude or prolapse into the vagina. The cervix shrinks, looks a little paler, thick, glistening epithelium on the surface. The uterus shrinks in size because of a decrease in myometrium. The vagina becomes shorter and narrower and less elastic. We have an increase in connective tissue. Without sexual activity, the vagina atrophies to half of its former length and width. The vaginal epithelium atrophies, becoming thinner, drier, and itchy. This causes fragility of the mucosal surface, so we have an increased risk of bleeding and vaginitis. Decreased vaginal secretions equal risk for irritation and dyspareunia, which is pain during sex. Vaginal pH becomes more alkaline, and this is from a decreased estrogen. Externally, the mons pubis looks smaller because the fat pad atrophies. The labia and the clitoris gradually decrease in size, and pubic hair becomes thin and sparse. As far as sexual response cycle, because of the declining estrogen levels, this produces some physiologic changes in the sexual response cycle. We have a reduced amount of vaginal secretions and lubrication during excitement, shorter duration of orgasm, and more rapid resolution. However, these changes do not affect the need or ability to have sexual pleasure. When performing the pap smear, it's better at screening squamous cells over adenocarcinoma. Due to pap smears, overall rates of cervical cancer have decreased in the U.S. The overall incidence of cervical cancer is increased in our Black patient population. One of the things to be aware of is female mutilation. It's also known as infibulation. This is an invasive surgical procedure usually performed on girls before puberty. It's a social custom practice with Aboriginal, Christian, and Muslim families who have emigrated to the U.S. from Western and Southern Asia, Middle East, and larger areas of Africa. The procedure involves removal, in part or total, of the clitoris and believed to inhibit sexual pleasure. About 130 to 140 million women alive today have had this procedure. It's outlawed in the U.S. Moving on to collect some subjective data from our patients, we've got a whole bunch to go through here, as you can see. We're going to ask our patients about urinary symptoms. Are they urinating more frequently? Do they feel an urgency where they can't hold it for very long? Is there any burning or other type of pain during, before, after urination? Do they have to wake up during the night to pee? Is that something that's unusual for them, something new? Is there any blood in their urine? Is it dark, cloudy, or foul smelling? Any suprapubic or flank pain? Do they have any difficulty controlling urine or wetting themselves? Do they urinate when they sneeze, laugh, cough, or bear down? And any other related symptoms such as fever and chills, nausea and vomiting, signs that would indicate that they may have some type of infection going on. We're going to ask them about any type of vaginal discharge. Is it unusual for them? Is there more than usual? When did it start? What color? Is it white, a yellow, green, gray? Is it curd-like? These are going to all kind of lead us to any type of abnormality or infection. Any foul odor with the discharge? Is it associated with any other symptoms like itching, rash, or pain with sexual intercourse? Are they taking any medications at this point in time? And do they have a family history of diabetes, as this increases their risk for some infections? Are they taking any medications if they are a diabetic, and which type of medications are they taking? We're going to ask them what part of the menstrual cycle they're in at the time that we're evaluating them. Do they use a vaginal douche? How often? Any other type of feminine hygiene spray? Do they wear non-ventilating underpants or pantyhose? Have they been treated for discharge with anything? There's plenty of over-the-counter medications out there. What did they use? What was the result? We're going to ask them if they routinely perform self-breast exams. Have they noticed any pain or lumps, any type of discharge from the nipple? Are there any concerns with rashes? Any changes, size and swelling? Any trauma to their breasts? Any pain, swelling, tenderness in the axilla? And have they used anything or done anything to treat these issues? Moving on to sexual activity, often the patient's going to have a question about their sexual relationship and how often it affects their health. So we're going to ask them a question like this, and we're going to present it in a way that makes them feel like they're just part of the average population. So stating a question like this, instead of just asking them straight up, how are things going, they'll likely answer just fine. But if we let them know that often people do have issues, then they'll feel that they're more a part of the norm. So asking a question like this is really important, and how you pose it, and that's something that's important for you to know. We can ask them if they're in a relationship that does involve sexual activity. Are there aspects of sex that are satisfactory to you and your partner? Are they satisfied with the way the partner communicates with them about sex? Are they satisfied with their ability to respond sexually? Do they have more than one sexual partner? What is your sexual preference, men, women, or both? This, again, is going to be a touchy subject with them at some point in time. You can word this question as well. Many people have a preference of one or the other or both. And it's important to know just in relation to their risk of infections. We're going to ask them if they're currently planning on becoming pregnant, or if they are attempting to avoid pregnancy. Do they use contraceptives? What's the method? Are they happy with that method? Do they have questions about other types of methods that they may want to utilize? What have they used in the past? Have they discussed with their partner having children? Have they had any problems becoming pregnant? Have they had any sexual contact with a partner having a sexually transmitted infection such as gonorrhea, herpes, HIV, AIDS, etc.? If they have, how long have you been sexually active with this person? When was the last time of sexual contact? Was the STI treated, and how was it treated? Were there any type of complications? Did it resolve? And then we're going to ask them about risk reduction. Do they use precautions for sexually transmitted infections? Do they use condoms for each sexual episode? Are they taking any type of preventative? Is it being taken consistently? And then moving on to their general history, we're going to ask them if they've got any other issues with the genital area, any types of sores or lesions they've had in the past or now. Then we'll actually have them describe them, if they ever were treated for them, what the diagnosis was. Do they have any type of abdominal pain or difficulty using the bathroom? Have they had any surgeries on their breasts, their uterus, ovaries, or vagina? Any history of cancer of any of these organs? Are they taking any medications, hormones, or birth control? We're going to ask them about their menstrual periods, the age that they first got their period, the date of their last menstrual period, how often do they occur, how many days do they last, is it a usual amount, light, medium, or heavy, does it vary, how many pads or tampons do they use each day on average? Do you have any clotting with your periods? Do you have any pain or cramps before or during your period? How do you treat them? Do they interfere with your daily activities? Are there any other associated symptoms such as bloating, breast tenderness, or moodiness? And do they have any spotting between their periods? If appropriate, we're going to ask them about their obstetric history, if they've ever been pregnant, how often, how many infants have you given birth to versus miscarriages or abortions. For each of the pregnancy, we want to know the duration, any complications with labor or delivery, the infant's gender, the birth weight, and the condition of the baby at the time that they were born. We're going to ask them if they think it's possible that they're pregnant now, and if so, what types of symptoms have led them to believe that. With our patients that are at or near menopause, we're going to ask them if their periods have slowed down or stopped altogether. Do they have any associated symptoms of menopause, such as hot flashes, night sweats, numbness, tingling, everything that you see here? And if they're using a hormone replacement, how much? What type is it? Are they having any type of side effects? Is it working for them? How do they feel about going through menopause? And then self-care behaviors. How often are they having a checkup with their gynecologist? When was their last pap smear? What the results were? Has your mother ever mentioned taking hormones or other drugs while pregnant with you? With our adolescent patients, we're going to consider who's in the room with the patient. They may not want to disclose anything if other people are in the room. And we're going to use questions to assess sexual growth, development, and sexual behavior. We're going to ask questions that seem appropriate for the girl's age. And when in doubt, ask too many questions rather than omitting something. We're going to ask direct, matter-of-fact questions, avoid sounding judgmental at all, and start with a permission statement, such as often girls your age experience sexual activity, they often experience mood swings, anything that kind of opens the mindset of your patient, because they're going to often feel very uncomfortable with this topic. So letting them know that they're part of a normal crowd by saying, other girls have these types of experiences, do you? And then use open-ended questions. When did you this, or do you that? This is less threatening because it implies that the topic is normal and unexceptional. Around the age of 9 or 10, girls start to develop breast and pubic hair. So we're going to ask them if they've ever seen charts and pictures of normal growth patterns. I have some of these we can review, and that's where you can pull out your Tanner chart. Have your periods started? How do you feel about it? Were you prepared? Were you surprised? Who in your family do you talk to about these types of body changes and about sexual information? Do you think that you get enough information? You want to make sure that you provide any information that they might have. You can ask them if they've got any education at school, sex ed. Is there a teacher, nurse, a minister, anybody outside of your family that you feel comfortable talking to about these things? And we can also say often girls your age have questions about sexual activity, and ask them about their dating and how they feel towards it. We're going to ask about their partners. Have they had intercourse? Are they using any type of protection? Has anyone ever talked to you about STIs, such as chlamydia, herpes, gonorrhea, or AIDS? Have you and your parents discussed HPV vaccine? It's recommended for girls who before they become sexually active. And then with our older women, after menopause, have you noted any vaginal bleeding, itching, discharge, or pain with intercourse? Any pressure in the genital area, loss of urine with cough, sneeze, back pain, or constipation? And are you in a relationship that involves sex right now? Are there any aspects of it that are satisfactory, unsatisfactory? Anything relating to that they may be uncomfortable with? And to touch on sexual assault really quick here, we do have a PowerPoint specifically on sexual assault. The guy has a lot of questions about collection of subjective data. It's a super complicated topic. It's not necessarily straightforward. The age of consent depends on state law. find out if the patient actually gave consent. If the consent is an issue for both genders, homosexual as well as heterosexual. So it's important for you to know that despite the gender of your patient, you need to ask these types of questions. And both partners need to consent. No consent doesn't mean consent. So it has to actually be something explicit that they talked about and both consented to. We are mandated reporters, so if we do have any type of concern involving a sexual assault, we're going to encourage the patient to be the one to report it if possible. But if we do have serious concerns about a certain situation, we have to report it. There are nurses that are certified, SANE nurses. It's a sexual assault nurse examiner. That's what SANE stands for. However, doing a sexual assault evaluation, the patient has to consent to it. It is not something that's mandatory. The reporting is mandatory, but the SANE workup is not. Moving on to the objective data that we're going to collect with our breast exam, we're going to assess for size, symmetry, contour, and skin color. We're always going to expect both breasts simultaneously to note any discrepancies between the two. And that's important for you to know. It's always best to teach the patient how to perform a breast self-exam while you're doing the breast exam on the patient or shortly thereafter. Here's an image that shows how to do a breast exam. It's a little bit tedious to go through and explain verbally here, so I do have a link there at the bottom. I encourage you to pause this presentation and go watch it really quickly. These should be done at the same point in the menstrual cycle because the differentiating levels of hormones cause different things to occur in the breast, whether there's tenderness, lumps, swelling. So it's important to let your patient know that this should be done at the same point in time during their menstrual cycle. And that is something that is important for you to know. This position here that's highlighted, this makes the significant size lumps, if they exist, more distinct when you're doing the exam. And that is also something that's important for you to know. And then we're going to move on to part 2.